Hello and welcome to today's lecture on hypertrophic cardiomyopathy. Please like the video and subscribe to the channel so that you do not miss any videos. Also, leave any suggestions you have or requests for future videos in the comments below. Let's begin. Introduction. Hypertrophic cardiomyopathy is defined as left ventricular hypertrophy that develops in the absence of causative hemodynamic factors, such as hypertension, aortic valve disease, or systemic infiltrative or storage diseases. It has been previously termed hypertrophic obstructive cardiomyopathy, asymmetric septal hypertrophy, and idiopathic hypertrophic subaortic stenosis. The accepted terminology is now hypertrophic cardiomyopathy with or without obstruction. Epidemiology. Prevalence in North America, Africa, and Asia is about 1:500. Pediatric presentation is associated with increased early morbidity and mortality. The prognosis for patients diagnosed as adults is generally favorable. Pattern of inheritance. Echocardiographic screening of families revealed an autosomal dominant pattern of inheritance. Mutations in sarcomeric genes are responsible for this disease. 80% of patients have a mutation in either MYH7 or MYBPC3. The presentation is age-dependent and incomplete penetrance is seen. Presentation. The phenotype of left ventricular hypertrophy is rarely present at birth and usually develops later in life. Accordingly, screening of family members should begin in adolescence and extend through adulthood. In MYBPC3 mutation carriers, the average age of disease development is 40 years, while 30% remain free from hypertrophy after 70 years. Related individuals who carry the same mutation may have a different extent and pattern of hypertrophy. Example, asymmetric versus concentric, occurrence of outflow tract obstruction, and associated clinical outcomes. Example, sudden death, atrial fibrillation. Pathophysiology. Hypertrophic cardiomyopathy mutations lead to enhanced calcium sensitivity, maximal force generation, and ATPase activity. Calcium handling is affected through modification of regulatory proteins. Sarcomere mutations lead to abnormal energetics and impaired relaxation, diastolic dysfunction, myocardial fibrosis, and microvascular ischemia also contribute to contractile dysfunction and elevated intracardiac pressures. Obstruction is present in 30% of patients at rest and can be provoked by exercise in another 30%. Systolic obstruction is initiated by drag forces, which push an anteriorly displaced and enlarged anterior mitral leaflet into contact with the hypertrophied ventricular septum. Mitral leaflet coaptation may ensue, leading to posteriorly directed mitral regurgitation. In order to maintain stroke volume across outflow tract obstruction, the ventricle generates higher pressures, leading to higher wall stress and myocardial oxygen demand. Smaller chamber size and increased contractility exacerbate the severity of obstruction. Concept. An important concept needs to be taught here. Imagine a hypertrophied septum. So any condition that reduces the volume of blood in the heart brings the septum closer and increases obstruction. This leads to increased symptoms. Also the murmur increases. Increased contractility also worsens symptoms. Anything that increases the volume of blood in the ventricle has the opposite effect as the septum is moved away and there is less obstruction. So symptoms reduce and murmur decreases. Reduced contractility improves symptoms. So, conditions of low preload, such as dehydration, and low afterload, such as arterial vasodilation, which leads to reduced blood volume in the heart, may lead to transient hypotension and near syncope. The systolic ejection murmur of left ventricular outflow tract obstruction is harsh and late peaking and can be enhanced by bedside maneuvers that diminish ventricular volume and transiently worsen obstruction, such as standing from a squatting position or the Valsalva maneuver. Pathology. It is characterized by misalignment and disarray of the enlarged myofibrils and myocytes. Although hypertrophy is the defining feature of hypertrophic cardiomyopathy, fibrosis and microvascular disease are also present. Interstitial fibrosis is detectable before overt hypertrophy develops. Focal areas of replacement fibrosis can be readily detected with MRI. These areas of scar may represent substrate for the development of ventricular arrhythmias. Microinfarction of hypertrophied myocardium is a hypothesized mechanism for replacement scar formation. Gross appearance. There is non-uniform ventricular thickening. The interventricular septum is the typical location of maximal hypertrophy. Hypertrophy confined to the ventricular apex, apical hypertrophic cardiomyopathy, is less often familial and has a different genetic substrate. Diagnosis. Patients may be diagnosed after undergoing evaluations triggered by the abnormal physical findings or symptoms of exertional dyspnea, angina, or syncope. Alternatively, diagnosis may follow evaluations prompted by the detection of disease in family members. Dynamic auscultation. Take a moment to study the slide. It is as we have discussed before. You may pause the video here if needed. Cardiac imaging. Cardiac imaging is central to diagnosis due to the insensitivity of examination and ECG and the need to exclude other causes for hypertrophy. Biopsy is not needed to diagnose hypertrophic cardiomyopathy but can be used to exclude infiltrative and metabolic diseases. Rigorous athletic training or athlete's heart may cause intermediate degrees of physiologic hypertrophy difficult to differentiate from mild hypertrophic cardiomyopathy. Unlike hypertrophic cardiomyopathy, hypertrophy in the athlete's heart regresses with cessation of training, and is accompanied by supernormal exercise capacity, that is VO2 max more than 50 ml per kilogram per minute, mild ventricular dilation, and normal diastolic function. Treatment. Treatment involves managing symptoms and prevention of sudden death and stroke. Left ventricular outflow tract obstruction can be controlled medically by beta-blocking agents and L-type calcium channel blockers like verapamil. These are first-line agents that reduce the severity of obstruction by slowing heart rate, enhancing diastolic filling, and decreasing contractility. Persistent symptoms of exertional dyspnea or chest pain can sometimes be controlled with the addition of disopyramide, an antiarrhythmic agent with potent negative inotropic properties. Patients with or without obstruction may develop heart failure symptoms due to fluid retention and require diuretic therapies for venous congestion. Interventions. Severe medically refractory symptoms develop in 5% of patients, for whom surgical myectomy or alcohol septal ablation may be effective. Mitral valve repair or replacement is usually unnecessary as associated eccentric mitral regurgitation resolves with myectomy alone. Alcohol septal ablation in patients with suitable coronary anatomy can relieve outflow tract obstruction via a controlled infarction of the proximal septum, which produces similar peri-procedural outcomes and gradient reduction as surgical myomectomy. Until long-term outcomes are demonstrated for this procedure, it is relegated primarily to patients who wish to avoid surgery or who have limiting comorbidities. Neither procedure has been shown to improve outcomes other than symptoms. With both procedures, the most common complication is the development of complete heart block necessitating permanent pacing. Patients with hypertrophic cardiomyopathy have an increased risk of sudden cardiac death from ventricular tachyarrhythmias. Vigorous physical activity and competitive sport are prohibited. An implantable cardioverter defibrillator is advised for patients with 2 or more risk factors and is advised on a selected basis for patient with 1 risk factor. Atrial fibrillation in HCM. Atrial fibrillation is common in patients with hypertrophic cardiomyopathy and may lead to hemodynamic deterioration and embolic stroke. Rapid ventricular response is poorly tolerated and may worsen outflow tract obstruction. B-adrenergic blocking agents and L-type calcium channel blockers slow AV nodal conduction and improve symptoms. Digoxin should be avoided, as they may increase contractility and worsen obstruction. Symptoms exacerbated by atrial fibrillation may persist despite adequate rate control due to loss of AV synchrony and may require restoration of sinus rhythm. Disopyramide and amiodarone are the preferred antiarrhythmic agents, with radiofrequency ablation considered for medically refractory cases. Anticoagulation to prevent embolic stroke in atrial fibrillation is recommended. Here is a flowchart that outlines management. You may pause the video here to look at the figure. Prognosis. The sudden death risk is less than 1% per year. The risk factors are as follows. One in 20 patients will progress to overt systolic dysfunction with a reduced ejection fraction with or without dilated remodeling, burned out or end-stage hypertrophic cardiomyopathy. These patients suffer from low cardiac output and have a high risk of death from progressive heart failure and sudden death unless they undergo cardiac transplantation. That's all for today. Let us know what topic to cover in the next video in the comments. Have a nice day.